So afterward, I'll show you. When is your exam actually?
For our part, will be on the 17th of June.
17th of June. This is for surgery, is it?
Yeah, for surgery.
Okay. ENT when?
ENT, I believe in November.
I see. Okay. So for this respiratory system, actually there are 6 lectures. So for this session, I only put for the first 4 lectures. For hypoxia and acclimatization to higher and lower altitude, if we have time, we will cover. If not, I'll just give you the notes for you to read and videos to support your understanding. Okay. Okay. So the first one is mechanics of ventilation. Okay. All these images are taken from my book. Okay. Physiology of Respiratory System back in 2018. Okay, from IIUM Press. I'm sorry I cannot share the PDF file to you because it's like breaking the rules with IIUM Press. Okay, but if you want to buy the book, you can buy from Shopee. You just click Physiology of Respiratory System, IIUM Press, it will come up. I'll show you the book later. Okay. So basically, you need to know what is in upper respiratory tract and lower respiratory tract. I'm sure you know, okay? And what are the importance of conducting zones and respiratory zones, okay? Alveoli, obviously, okay? And what are the physiological function of respiratory system? Basically to provide oxygen, eliminate the carbon dioxide, okay? Regulates our pH for phonation and also defends against microbes, toxic and foreign matters. Okay, I'm sure you know what is pulmonary ventilation, inspiration and expiration. Maybe later you can read. Okay, you need to know what is external respiration and internal respiration, what happened there. And yeah, relation to of the lungs to the thoracic walls. Okay, what are the thoracic pressures? You have atmospheric pressures, you have alveolar pressure. Okay, you need to know what is the definition, intrapleural, transpulmonary pressure. I'm sure you know about it. Okay, the muscle of respiration is also important. If I give you a case scenario, so you need to know in forced expiration, forced inspiration, which one is involved? Okay. There will be a case scenario in your question. Did you get my email yesterday regarding questions and also lecture notes?
I believe Dr. Haris already received it.
Do you guys open the file and go through?
He said because he got some difficulty with his internet. He just went through today morning. I think he will display.
Okay. So if you have time, go through the case file for physiology. That one is very good because it has the whole system from action potential until the whole system for physiology. So it gives you the explanation for the questions and also the short notes. Some of my questions are also from there. Okay, so if you got time before the 17th, so please go through that one and also try to answer the MCQ questions that I've given. There are many, just try. Okay. Okay, these are the mechanics of ventilation. Okay, you know what happened, right? Before inhalation, during inhalation, exhalation. Okay. What are the pressure involved and how is the changes? You need to know. Okay, mechanics of ventilation. I'm not going to go through because you request me lung functions. Okay. Factors affecting ventilation, airway resistance, compliance. What are the example of decreased compliance? You need to know. Okay, increased compliance, alveolar surface tension. Okay, also affecting the ventilation. You need to know as well. There is also a case scenario that I've given according to this alveolar surface tension. Okay, please read through. Okay, now lung volumes and capacities. Okay, for lung volumes and capacities, you need to know what are the definitions for the lung volumes. and also the lung capacities. Okay, what are the changes during obstruction and restrictive? What happened during obstructive and what happened during restrictive, you need to know as well. So the tidal volume normally is 500 ml, okay? So that by definition is amount of air exhale, inhale during one relaxed breath, okay, quiet breathing. Inspiratory reserve volume, normally we'll ask undergraduate if we ask the discuss lung volumes and capacities, we expect them to draw and to define what are the lung volumes and capacities. But when they go to second year, we ask them to describe about the changes of lung volumes and capacities during obstructive and restrictive. So for your level, you need to know the basic and also what are the changes during obstructive and restrictive. An example of obstructive and restrictive lung disease, okay? So during normal, okay, you need to know the FEV1, FVC ratio is more than 80, right? This is in normal flow volume, volume over time graph, okay? And this is in obstructive case, okay? When there is reduce in FEV1 or reduce or normal FVC, forced volume capacity, okay? So the ratio should be less than what, 70, right, in obstructive. In restrictive, you can get normal values or slightly reduced from the normal graph, okay? This is the normal graph and restrictive, okay? So this is from my book, which I draw, the volume over time loop, okay? This is the FEV1, this is in normal, and this is in obstructive and restrictive. So when you do the calculation for FE1, FVC ratio, you will get the normal for restrictive lung disease. But when you see the graph, it's more reduced in the number of volume, okay? Okay, this is flow volume loop. This is the inspiration curve, and this is the expiration curve. This is the PEFR, peak expiratory flow rate, okay? In obstructive, you can see coving. In restrictive, you don't see coving, but it's more, you can see obviously reduced from the normal lungs flow volume loop, okay? So the FVC is reduced, okay? This one you have coving. So for obstructive, you have reduced PEFR severely, okay? And normally when we conduct lung function tests for the undergraduates, we give them this video for them to watch, and also we give them questions to answer whether it's obstructive, restrictive, or mixed, okay? We give them both flow volume loop and volume over time graph, okay? So they need to identify whether it's obstructive, restrictive, and give the example. So this one I've already given the answer. Okay, this is also taken from my book. Okay, we compare normal lung to obstructive lung. So in obstructive lung, you have tidal volume increase, residual volume increase, functional residual capacity, and TLC, total lung capacity increase. The rest of it reduce. Why is it in obstructive lung these values are increased? Why?
Because the air to expire also obstructed.
Okay, good. Okay, so in restrictive lung, restricted lungs, all the lung volumes and capacities are reduced. Okay, can you explain why?
Because there is limitation on air entry into the lung.
Good. That means there is a problem in expanding the lungs. Okay. Okay. So this one is the flow volume loop. Okay. Normally we ask the undergraduate to label it. Okay. What are the peak expiratory flow rate, residual volume? Okay. Where do you identify the residual volume, total lung capacity, and forced vital capacity? Okay. Respiratory rate, I'm sure you are well versed. Okay. Okay. That space, you need to know about that space as well. Okay. Volume of air occupying the space in the conducting zone. Okay. Physiological dead space is volume of air not equilibrating with the blood, or you call it wasted ventilation. Okay. when there's increase in dead space volume, so there's decrease in alveolar ventilation. So how do you calculate alveolar ventilation? So the tidal volume minus the dead space volume, which is 150, okay, dead space volume or the anatomical dead space. So it times 12 with the respiratory rate. So you get, and then pulmonary ventilation or minute ventilation, tidal volume times the respiratory rate. So alveolar ventilation is very important for the effective gas exchange. Okay, so these are the non-respiratory air movement. I'm sure you are well versed. Okay, so now we go for exchange and transport of gases. So for exchange and transport of gases, you need to know what is Dalton's law and Henry's law. Okay, what does it say? Okay, so in Dalton's law, it explains on how gas move from their pressure differences by diffusion. And Henry's laws explain how solubility of gas related to its diffusion. Okay, how pressure play a role and how solubility play a role to its diffusion. So Dalton's and Henry's law. Okay, this one I'm sure you can read through. Okay, so when there's a mixture of gas diffuses across the permeable membrane, so each gas will diffuse from area from its partial pressure where it's greater to lesser one. Okay, so the greater partial pressure difference, the faster the rate of diffusion. Okay. And now external respiration is the exchange between oxygen and carbon dioxide between the air in the alveoli of the lung and the blood pulmonary capillaries. Okay. So what are the factors influencing the external respiration also is important. So you need to know the partial pressure play a role. Okay. So when there is increase in altitude, what happened? So the rate of diffusion is faster when there's increase in when there's the difference between the partial pressure oxygen in the alveolar air and the pulmonary capillary is larger, in the blood is larger. Okay. So when the alveolar partial pressure decreases, oxygen diffuse into the blood more slowly. Okay, so that's what happened in high altitude sickness. Okay. And then the surface area for gas exchange that also play a role in the external respiration. Okay. When you have pulmonary disorder like emphysema, so it decreases the functional surface area. So it decreases the external respiratory rate. And then diffusion distance. If the total thickness of the respiratory membrane were greater, so the diffusion will be slower. Okay. And then internal respiration. So the exchange between the exchange of oxygen and carbon dioxide between the systemic capillaries and also the tissue cells. Okay. So transport of oxygen and carbon dioxide, I'm sure you know. Okay, hemoglobin bind with oxygen become oxyhemoglobin. When it's dissociate become deoxyhemoglobin or reduced hemoglobin. Okay. So this one is telling you the external and also the internal respiration. Okay, you can go through. I'll share you all these slides. Okay, now we will see the relationship between the hemoglobin and oxygen partial pressure. Okay, the higher the partial pressure of oxygen, the more oxygen will combine to the hemoglobin, right? So when reduced hemoglobin is completely converted to oxyhemoglobin, then that one is called fully saturated. Okay, when the hemoglobin is consists of part of mixture hemoglobin and oxyhemoglobin, then you call it partially saturated. Okay. So when the partial pressure of oxygen is between 60 to 100, that means hemoglobin is more 90% or more saturated with the oxygen. When the partial pressure is between 40 to 60, and large amount of oxygen will be released from the hemoglobin in response to small decrease in partial pressure. Okay. So as we can see, as the pressure increase, more oxygen, what? More oxygen will be what?
Higher affinity.
Okay. Okay. So now we go to the first factor affecting the factors affecting the hemoglobin affinity for oxygen. So acidity. So when there's increase in acidity, where pH decrease, right, the affinity for hemoglobin for oxygen decrease. Okay, so more oxygen dissociate more readily from the hemoglobin. Okay, when the pH decrease, so the entire oxygen dissociation curve shift to the right. Okay, when it shifts to the right, that means oxygen is going towards the tissue rather than in the blood. Okay, so HB is less saturated with the oxygen, so that is called Bohr effect. Okay, at any given partial pressure. So Bohr effect is where the hemoglobin acts as a buffer for hydrogen ion. So when the hydrogen binds to amino acid in the hemoglobin, so they slightly alter the structure, so therefore decrease the oxygen carrying capacity. So when there's low pH, it dries off the oxygen from the hemoglobin, so that more oxygen is available to the tissue cells. So this is what I meant. So when the curve is shifting to the right, that means it's more going, the oxygen is going to the tissue. Okay. So when it's moving to the left, that means it's bind to the hemoglobin. Okay, saturated to the hemoglobin. So as you can see here, high blood pH, so it's more towards to the left. So that means it's more saturated to the hemoglobin. Low blood pH, that means it's dissociate, so more oxygen is readily to the tissue. Okay, so partial pressure of carbon dioxide is also related to the acid. So when there's increase in carbon dioxide, what happens? Is it acidity or alkali?
Alkali.
Huh? I can't hear you. More carbon dioxide, acidosis or alkalosis? Acidosis, right? Okay. So if you can forget, you just look at the carbon dioxide plus water forming carbonic acid when it breaks down. So more hydrogen, right? Carbon dioxide increase, the H, when it breaks down, the hydrogen also increase. So that's why pH decrease, more acidity. Okay. So when there is also increase in carbon dioxide, so decrease in blood pH, right? So the curve will shift to the right. So more oxygen will be available to the tissue. Okay, high PCO2, that means low blood pH. So low PCO2, that means high pH, that means more shifting to the left. Okay, so when it's more shifting to the left, what happened? More oxygen binds to the hemoglobin. Good. Okay, so temperature, when temperature increase, what happened? So heat is a byproduct of metabolic reaction. Okay, so the heat released by contracting muscle fibers tend to raise the body temperature. Okay, so metabolically active cells require more oxygen. Okay, so liberate more acid and heat. So when there's increase in acid, heat, so it promotes oxygen release from oxyhemoglobin. Okay, so in hypothermia or during winter time, the cellular metabolism is low. So the need for oxygen is reduced. So more oxygen is bound to the hemoglobin. So the curve is shifting to the left. Okay. So this one here, if it's moving to the right, that means the oxygen is going to the tissue. So if it's to the left, that means it binds to the hemoglobin, saturated with the hemoglobin. Okay, easy to understand the oxygen dissociation curve?
Yes.
Okay, and then BPG. BPG is a substance that found in the RBC, or you call it DPG. Okay, so DPG is formed from the RBC when it breaks down glucose to produce ATP. Okay, so it's a process in the glycolysis. So when BPG bind to the hemoglobin, hemoglobin will be tightly bind less tightly to the oxygen. Okay, so it will unload more oxygen from the hemoglobin. Okay, so there are several hormones that can increase BPG. Okay, normally I like to ask students what hormones that play a role in increasing affecting the oxygen dissociation curve to the right. So you have to think the BPG and then what hormones. Okay, so BPG also increase in people who are living at the high altitude. Okay. And then oxygen affinity to the of fetal and maternal blood, maternal hemoglobin. So fetal hemoglobin has a different structure from the adult hemoglobin. Okay, so it has higher affinity to the oxygen, so it binds less to the BPG. Okay, so when the partial pressure of oxygen is low, okay, HbF can carry up more than 30% oxygen than the maternal hemoglobin. Okay, so as the blood enters the placenta, okay, the oxygen is readily transferred to the fetal blood, but the oxygen saturation in the maternal blood in the placenta is quite low, so the fetus might suffer a hypoxia. So that's why you have the HbF have a greater affinity for the oxygen. So if you see here, the maternal is on the right and the fetal one is on the left. So when it's on the left, that means HbF is more binding with the oxygen. Okay. So carbon dioxide transport. So there are three main forms of carbon dioxide being transported in the blood. One is dissolved carbon dioxide, it's about 7%. One is carbamino compound, okay, you call it carbamino hemoglobin, okay. Another one is as bicarbonate ion, okay. So when the bicarbonate ion accumulate in the RBC, some will diffuse out into the plasma down to its concentration gradient. So you have, when you exchange it, exchange with the chloride ion, diffuse into RBC. So when there is exchange between bicarbonate and chloride ion, that's where you call chloride shift to maintain the electrical balance between plasma and red blood cells, okay. So this is the chloride shift here, okay, oxygen release and carbon dioxide picked up at the tissue. This is not from my book because this is from the textbook. And this is where reverse chloride shift happen when oxygen picked up and carbon dioxide released in the lungs. Okay, Haldane effect is the amount of carbon dioxide that can be transported in the blood that is influenced by the percentage of saturation of hemoglobin within with oxygen. So when there's lower oxyhemoglobin, the higher carbon dioxide carrying capacity. Okay. So now we go for ventilation perfusion relationship. Okay. Okay. What is ventilation? So it's the movement of air between the atmosphere and the alveoli. Okay. Perfusion is the movement of blood through the pulmonary capillaries. So basically how perfusion is how the gas can get across to the alveoli, the gas exchange. Okay. So ventilation is the movement of the air. Perfusion is more about the gas exchange. Okay. So this one you can read pulmonary blood. Yes. Okay, pulmonary blood flow. Okay, by definition is cardiac output of the right heart, which is equal to the cardiac output of the left heart. Okay, so pulmonary blood flow is directly proportionate to the pressure gradient between the pulmonary artery, left atrium, and also inversely proportionate to the resistance in the pulmonary vasculature. So Q is equals to the pressure difference divided by the resistance. So when you compare with the systemic circulation, the pulmonary circulation is characterized by low pressure and also low resistance, although the blood flow is the same. Okay, the reason why the blood flow, pulmonary blood flow is equals to systemic blood flow is because the pulmonary pressure and the resistance are proportionally lower than the systemic pressure and resistance. Okay, so what regulates in ventilation and perfusion? You need to know what regulates the pulmonary blood flow. Okay, normally I like to ask this question: regulation of pulmonary blood flow. Okay, to the undergrads. So hypoxic vasoconstriction is one of the factors that regulate the pulmonary blood flow. Okay, partial pressure of oxygen in the alveolar gas is the major factor. Okay. When there's reduced in alveolar oxygen partial pressure, right, it produces the pulmonary vasoconstriction, hypoxic vasoconstriction. Okay, so When the partial pressure of alveolar oxygen is normal, okay, the oxygen diffuses from the alveoli into the nearby arteriolar smooth muscle cells. So it will keep the arteriole relaxed and dilated. But when the pressure is reduced between 100 to 70, the vascular tone is minimally affected. When it's reduced more, like less than 70, okay, the vascular smooth muscle cells will sense the hypoxia. So it will vasoconstrict and reduce the pulmonary blood flow in that region. Okay, so the alveolar partial pressure of oxygen play a role in the regulating the pulmonary blood flow. Okay, so it is believed that hypoxia can cause depolarization of the vascular smooth muscle. Okay, and it opens up the calcium voltage-gated calcium channels, leading the calcium entry into cells and causing contraction. Okay, that's why hypoxic vasoconstriction. Okay, nitric oxide also can play a role in regulating the pulmonary blood flow, while okay, and it also can relax the vascular smooth muscle. So inhibition of nitric oxide synthase enhances the hypoxic vasoconstriction. Okay, now you need to know what are the distribution of the pulmonary blood flow. So when in supine, the blood flow is uniform, okay, since the entire lungs are not at the same gravitational level. Okay, when a person is in upright position, okay, the gravitational effects are not uniform, okay. The blood flow is the lowest at the apex of the lungs, the zone 1, highest at the base, okay. Zone 1 is the lowest and highest at the base of the lung, which is zone 3, okay. Now we will see, don't worry, I will share you the slides, okay. I will not alter anything, okay. I will share you slides, you just listen. Okay, in zone 1, okay, at the apex of the lungs, if you can see here, partial pressure of alveolar is higher than the partial pressure of arterial, and the partial pressure of arterial is higher than the venous partial pressure. Okay, so if the partial pressure of arterial is less than the alveolar, the pulmonary capillaries will be compressed, okay, by the higher alveolar pressure outside of them. So this compression will cause the capillary to close and reduce the regional blood flow. Okay, so normally in zone 1, the arterial pressure is just high enough to prevent closure, so that zone 1 is perfused at low rate. Okay, perfused at low rate. Okay, so zone 1 is low blood flow and low perfusion. Okay, so V is low, Q is low. Okay, V is the ventilation, Q is the perfusion, which is the gas exchange. So in case there is increase in arterial pressure, okay, due to hemorrhage, or alveolar pressure by increase due to positive pressure breathing, then the partial pressure of alveolar is higher than the arterial partial pressure. So the blood vessels will be compressed and closed. So under this condition, zone 1 will be ventilated but not perfused. Okay, so there won't be any gas exchange. Okay, so zone 1 will be physiological dead space. Okay, so it will be ventilated but not perfusion, not perfused. Okay, in zone 2, the middle of the lungs, the arterial partial pressure is higher than the alveolar partial pressure, and the alveolar partial pressure is still higher than the venous partial pressure. Okay, this is due to the gravitational effects on the hydrostatic pressure. Okay, and in zone 3, the arterial partial pressure is higher than the venous and the alveolar. So the gravitational effect has increased the arterial partial pressure and also venous partial pressure. So these two partial pressure now in arterial and venous are higher than the alveolar. Okay, so that's why in zone 3, the greatest numbers of capillaries are open, blood flow is the highest. Okay, so the ventilation is also higher, the blood flow is the higher. So there is also plenty of gas exchange. So the V is higher, the Q also higher. Okay, so this is a graph just to show the at the base the blood flow is higher, and when it comes to the apex the blood flow is lower. Okay. Okay, so this is what I've already explained just now. Blood flow is the lowest at the zone 1 and highest at the zone 3, the base. Okay, so these are the partial pressure driving the blood flow. So when you explain, if they say you have a short nose or you have an essay, what pressure regulates, you explain about the 3 partial pressure in alveolar, arterial, and also venous. Okay, and explain in 3 zones what happened. Okay, so this is what I meant. You see here, it's zone 1 where the alveolar partial pressure is higher. Okay, if you see here, the arterial pressure is what? 0, right? The alveolar partial pressure is 2. So the venous pressure is what? 0. Okay. And as you go to zone 2, the arterial partial pressure is getting higher. Okay, alveolar partial pressure, what? 2, 4, 6, 7 maybe. Okay, so this one is more higher. Okay, and this one is still, the alveolar partial pressure is still higher. Okay, and then here in zone 3, 2, 4, 6, alveolar partial pressure is reduced. So the arterial partial pressure is higher and the venous pressure is more higher than the alveolar partial pressure. Okay. Okay, now we go for the ventilation perfusion ratio. Okay, the VQ ratio. Okay. So why is it important to know the ventilation perfusion? Because you want to identify whether is there any dead space, shunt, or a high VQ or low VQ area. Okay.
Dr. Ruslina, sorry interrupted. Saya tak faham sangat yang previous slide tu, Dr. Ruslina.
This one?
The previous slide yang the zone tu.
Zone ni.
Maksudnya if alveolar pressure dia akan reducekan the exchange ke atau?
Because okay, this one here, when the alveolar pressure is higher enough, okay, high enough. Okay, so in zone 1, the arterial pressure is just high enough to prevent the closure. Okay, just high enough to prevent the closure. So zone 1 is perfused at a lower rate. So in zone 1, the blood flow is there, but it's very minimal. The highest is at the zone 3, at the base. Okay, in case there is an decrease in arterial pressure, that means due to hemorrhage, or there is increase in alveolar pressure due to positive pressure breathing. So that's where the alveolar pressure will be higher, right? More than the arterial pressure. So it will compress and closed. Okay, when the alveolar pressure is higher and compressed and closed, what will happen? It won't allow the blood to flow, isn't it? When the blood is not flowing, how the gas exchange can occur?
Okay.
You understand?
Okay, faham. Alright. Thank you.
So this is what I meant. So in case there is increase, the alveolar pressure is higher. That means due to any hemorrhage or positive pressure breathing or something. So the alveolar pressure will be more higher than this. Then it will just compress and it won't allow any blood flow to the venous level, right? So there is ventilation but no perfusion because it completely compressed. So in this zone 1, the alveolar pressure, the arterial pressure is just high enough. If you see here, maybe we can say 3, right? Here maybe 2. So it's just high enough to prevent the closure of the alveolar pressure. I mean, higher than the alveolar pressure. So the blood can flow through, right? There's ventilation and the blood flow through, but very minimal. So that's why in the zone 1, the blood flow is low. Okay, the ventilation is low, the blood flow is low. Okay, so maybe we can assume the blood flow in the apex is
so meaning as the increasing of the punya arterial pressure tu,
yeah, arterial pressure just high enough to prevent closure of the arterial pressure.
Kalau tak close, maksudnya exchange will be there lah.
Yeah. Okay. If in case there's positive pressure breathing or in any hemorrhage, then it will close. So when it's closed, it doesn't prevent any gas exchange. So it becomes wasted ventilation. You have the ventilation there, but there's no gas exchange. You will see the VQ mismatch after this.
Okay.
Okay. So now, why is it that you need to know about VQ ventilation perfusion? Because you need to know the ideal gas exchange. Okay, so it's useless for the alveolar to be ventilated but not perfused. Okay, let's say in that space, you have ventilation but no perfusion, or you have alveoli to be perfused but not ventilated. That means shunt. Okay, so the normal VQ is 0.8. So alveolar ventilation assuming 4, and then the pulmonary blood flow, the Q is 5 liters per minute. So 4/5, you get 0.8. Okay. So the term normal means if the breathing frequency, tidal volume, the cardiac output is normal, so the VQ will be 0.8. Okay, so we assume that the arterial oxygen level also will be normal, and the arterial carbon dioxide level also will be normal. Okay, if the VQ is normal, that means normal ventilation, normal perfusion, so the VQ ratio will be higher. So it will be lower. Okay. So now, as you can see here, just now we said blood flow. Blood flow, how much? Highest at the zone, at the base of the lungs, right? 4. And then the V is 4 and the Q is 5. Okay, 5 liters per minute. So 4/5, you get 0.8, or sometimes you can get 0. If it's lower than that, you can get 0.6. If the blood flow is lower, right? The ventilation is lower, the blood flow is lower, you get the higher VQ. Yes or no?
Yes.
If let's say the ventilation is 0.1, and then the perfusion, the Q is 0.3, how much do you get? How much do you get? 0.1 divided by 0.3, how much do you get?
3.
Huh?
3%.
3. That means the VQ ratio is at the highest. Okay, V/Q ratio is at the highest. Okay, let's say if you have alveolar ventilation for the base zone 3, you get 4 liters, and the Q is 5 liters per minute. How much do you get? 0.8, right? So there is higher ventilation, higher perfusion. Okay, so the VQ ratio will be lowest. Okay, what happened to the partial pressure of arterial oxygen level when there's normal ventilation, higher ventilation, higher perfusion? Okay, there is gas exchange. So when there is gas exchange, what happened to the oxygen level? It will go into the tissue, right? So the tissue will be using it, right? Yes or no?
Yes.
So the partial pressure of arterial oxygen level will be lower, and the carbon dioxide partial pressure of carbon dioxide will be higher because there is gas exchange from the tissue to be transported out to the lungs, right?
Yes.
Okay, so there's gas exchange. So that's what it meant, the higher partial pressure of carbon dioxide in the arterial. Okay, but if you see in zone 1, the blood flow, the ventilation is lower, the blood flow is lowest, right? So the VQ ratio will be higher. Okay, so in zone 1, the ventilation is lower, the perfusion is lower, so less, right? So the partial pressure of oxygen will be higher because, you know, the ventilation is lower, the gas exchange is minimal. It's there, but minimal. Okay, in zone 3, it's all at the highest level. That means gas exchange is efficiently over there. So that's why the arterial partial pressure of oxygen is lower and carbon dioxide is higher. Here, the gas exchange is in minimal. There is gas exchange, it's not being blocked, but in the minimal. So that's why still the arterial partial pressure of oxygen in the zone 1 is still highest, and in zone partial pressure of arterial carbon dioxide is lower. Do you understand this?
Dr. Roslina,
Yeah.
why when in zone 1 the gas exchange is low, the PCO2 is still low? Shouldn't it be higher?
Okay, why is it low? Okay, the blood flow is low, the ventilation is low, right? The alveolar ventilation is low, right?
Yes.
And the blood flow is the lowest, right? Okay.
Yes.
When there is lowest, right? How about the gas exchange? Is there, but the process, you know, the if you see if you compare base and at the apex, right? Maybe at the apex is 100%. Okay, the gas exchange, but in the apex maybe 10%, Okay, so that's
Okay.
why the percentage of arterial carbon dioxide oxygen level is highest because there is a minimal gas exchange. Minimal
Yes.
exchange. And the arterial carbon dioxide, you know, from the tissue to be transported out. So the gas exchange is minimal. Faham tak?
Okay.
So that's why it's lower. The gas exchange process occur, but the percentage is lower in the apex. In the base, it's at the highest. That's why the carbon dioxide from the tissue being exchanged out. Okay? You understand? The process of gas exchange.
Yes.
Okay tak? The doctor who asked me question just now, the lady, do you understand?
Yes, Dr. Roslina, I understand. Thank
Thank
you.
you so much. Okay. Okay, so this is what I meant just now. Okay, the VQ. Okay, ventilation is higher at the ventilation and perfusion are higher at the base. Okay, when and then at the apex is the lowest. So when you see the VQ ratio is higher at the apex and lowest at the base. Okay. So this is also the same thing, what I mentioned just now, the VQ at highest at the zone 1, lowest at the zone 3. Okay. Okay, now we go and see what are the VQ perfusion defects. Okay. So this one is quite important. There are 4 defects. One is dead space. Okay, I'm giving you example. Okay, high VQ, low VQ, and shunt. Okay. So a VQ defect can be caused by ventilation of lung regions that are not perfused. Okay, there is a ventilation but no perfusion, so that is called dead space. Or perfusion lung regions that are not ventilated. That means ventilation problem. Okay, so it's shunt. So let's see one by one. So this is the normal VQ mismatch, VQ matching. So normal ventilation and normal perfusion. Okay. So if you see here that space, the VQ is infinity. That means you have ventilation, but something wrong with the perfusion. You understand? Okay, here another one. For example, second example is high ventilation, low perfusion. If you can see here, the blood vessel is a bit smaller, just to make you understand the low perfusion. And this one, you have low ventilation, okay, and higher perfusion. And here, there's no ventilation, normal perfusion. Okay? Okay, now let's see one by one. What are the changes? Okay, so in that space, the VQ is infinity. That means you have ventilation but no perfusion. So ventilation is lung regions that are not perfused. So you call it wasted ventilation. Example is in PE. Okay, there's no gas exchange possible in that space. Okay, because there's no blood flow. Okay. In this region of that space, there's no gas exchange occur. So the alveolar gas is similar as the composition as humidified air. Okay, you see the alveolar oxygen partial pressure is 150 and alveolar carbon dioxide is 0 because there's no gas exchange. There is ventilation but no gas exchange. Do you understand this?
Yes.
Okay, good. So now the second scenario is high VQ. Okay, high VQ, that means high ventilation relative to perfusion. Okay, usually blood flow is decreased. Example is emphysema. Okay, that means high VQ have some blood flow. Okay, have some blood flow. That means the blood flow is a bit reduced, but there is. Okay, so high VQ. Okay, so because of ventilation is relative high to perfusion, okay, pulmonary blood capillary from this region have high high O2 and low PCO2. Okay.
What's that again?
What's that meaning? What happened? There is a ventilation, right? There is a ventilation, but the perfusion, the gas exchange is there but minimal, right?
Yes, yes.
So the oxygen cannot be entering the tissue, right?
CO2.
But
Nutrient level like.
You have low carbon dioxide because the carbon dioxide can move through from the blood flow, from the tissue to the primary capillaries, right?
Yep.
So that's what it meant. That means the blood flow is there but very minimal. You have high ventilation, high VQ. Okay? Okay, and then the third one is low VQ. That means low ventilation here, low ventilation, the normal normal perfusion. Okay, so example of low VQ can be chronic bronchitis or pneumonia. Okay, okay, low ventilation to perfusion usually because of ventilation is decreased. Okay, so because ventilation is relatively low to the perfusion, the pulmonary blood capillaries in this region have low O2, okay, and high PCO2. Okay, low O2 meaning the ventilation is reduced, right? Okay, so that's why low O2, right? And high PCO2, that means the carbon dioxide from the tissue can be exchanged, right?
Can exchange.
Uh,
But can expel.
and then number 4, the shunt, where there is absence in ventilation. Okay, absence in ventilation, but the perfusion is normal. Okay, so example are right to left shunt and also air obstruction. Okay, that means example of perfusion lung regions that are not ventilated. That means there's no ventilation. No gas exchange is possible because there is no ventilation. So this one is, there is gas exchange, right?
Yes.
Because it's coming from the tissue, right? The arterial oxygen level is low, the carbon dioxide is higher because you need to do gas exchange, right, from the tissue. So the tissue will release out the excess of carbon dioxide, right?
Yes.
So you understand now the 4 VQ defects? I hope you understand. So this one are the comparing of normal, shunt, and also dead space lah. If you see here, normal here, the alveolar partial pressure of oxygen is 100, carbon dioxide 40, arterial 100, carbon dioxide, arterial carbon dioxide 40. Here in obstructive, when obstructive, you don't have the alveolar doesn't have what happened? Obstructive. There's no ventilation, right? There's no ventilation. So from the arterial, what can be exchanged from here, like just now when I explained the shunt here. Okay, and then the pulmonary dead space, the VQ is infinity. So the alveolar partial pressure of oxygen is 150, but here there's no gas exchange because here is being blocked. Okay.
Right.
Okay. So this is for ventilation perfusion. You must understand what regulates the pulmonary blood flow, what are the pressure playing role, okay, and then which zones are in highest blood flow and ventilation, what are the VQ ratio, okay, where is the highest, where is the lowest, and then when you understand that, you apply all these 4 VQ defects, okay, that space, the high VQ, low VQ, and also the shunt, okay, and then try to make, when you don't understand, look back at the picture, okay. So this one is for the perfusion, sorry, this one is for the perfusion, this is for the ventilation, okay, and relate back. If you still don't understand, you can let me know, okay. If you feel shy, you just WhatsApp me, it's fine. Okay. Okay, now let's go on the regulation of respiration. Okay, respiratory center, there are 3. Okay, medulla oblongata, pneumotaxic area, acoustic area, upper pons and lower pons. This picture is also from my book. Okay. Okay. Basically, for the respiratory center, you can read through. Okay. So you have this inspiratory respiratory center, dorsal respiratory group. Okay. I've already explained here how does action potential again exert the effects and causing the functions of dorsal respiratory group. Okay, expiratory center, ventral respiratory center, you can read through, it's readable. Okay, pneumotaxic area, okay, the function is to transmit inhibitory impulse to the inspiratory area. Okay, amniotic area, so it sends stimulatory impulse to the inspiratory area, so and activate it for prolonged inspiration, so it inhibit the expiration. Okay, and then you also need to know, understand there is also cortical influence on the respiration. Okay, you are unable to hold your breath for so long. Okay, so even if you faint, your breathing resumes. Okay, even when you are unconscious. Okay, and then it's very important for you to know the chemical regulation of respiration. Okay, so there are two. One is central chemoreceptors and peripheral chemoreceptors. Okay. This is also important. I always ask the undergrad student, how does chemical regulation of respiration? So I want them to remember this equation, carbon dioxide plus water forming carbonic acid. Okay. So when there is hypercapnia, what happened? The chemical chemoreceptors are being stimulated to the increase in higher hydrogen ion in CSF. Okay. So hydrogen ion and carbon dioxide concentration fluctuates more readily in the CSF rather than in blood. So because CSF contains fewer buffer than blood. So the peripheral chemoreceptors in the carotid and aortic bodies will stimulate the are stimulated by increase in PCO2 and hydrogen ion. Okay, so they will have to draw this normally. Okay, this one also same, still under chemical regulation. Okay, and then what are the other factors that influence the regulation of respiration? Proprioceptor input and respiration. Okay, and then Herring-Brewer reflex. Okay, you need to know that. And then what are other influences on the respiration? There are limbic system, temperature, pain, stretching of the anal sphincters, irritation of airways. Okay, blood pressure, J receptor, you need to know this. Okay, you can read through later. Okay, and this image is actually summarizing what are the regulation of respiration lecture. Okay, and this one also from my book. Okay, what I've explained in the previous slides are summarized here by picture, image. Okay, and thank you. I wanted to show you some videos. Can I stop sharing and I show the video, yeah?
Sure.
Many have struggled to understand the dissociation curve, and quite honestly, instructors have had a difficult time teaching it. Let's stop complicating the simple. The dissociation curve is a great and simple tool for every practitioner. First, the curve reveals that as you apply more pressure in oxygen, it will saturate or occupy a greater percentage of blood. We see that here. More pressure equals more saturation. You can even make some predictions. For example, if the oxygen is pressurized to 60, it will saturate about 90 to 92%. If the oxygen is pressurized to 80, it will saturate about 95% of the blood. That is why, in general, we want the pressure of oxygen to be between 80 to 100, because the curve reveals to us that this amount of pressure saturates the most amount of blood. What we don't want is for the pressure of oxygen to decrease below 40. that's where saturation decreases drastically. And that's not good. That's called dissociation. Oxygen jumps or dissociates from the blood. As a side note, there's also some landmarks that you should learn, like the P50. The P means percentage. So the P50 is the 50% saturation mark. And the question is, how much pressure is required to saturate the blood to 50%? Answer, 27 millimeters of mercury. And so the P50 is normally 27. But what if the graph shifts to the left? Well, if the graph shifts to the left, you will notice that one positive thing happens. The blood becomes more saturated with oxygen. However, if the oxygen is in the blood, it must not be in the tissues. And we call that hypoxia. So then, what can cause a shift to the left? First, cold slows down transfer. So if the patient has a decrease in body temperature, oxygen will not transfer effectively to the tissues and will remain in the blood. What else can cause a shift to the left? Well, if there's more oxygen in the blood, that must mean that the enemy of oxygen must not be in the blood. Therefore, a decreased CO2 level in the blood can also cause a shift to the left. How does someone have reduced levels of CO2 in the blood? Answer, they blow it out. And that's called hyperventilation. And a drop in CO2 causes a rise in the blood pH. And this is called respiratory alkalosis. So what if the graph shifts to the right? Well, if the graph shifts to the right, you will notice that less oxygen is in the blood. And we call that hypoxemia. And what can cause a shift to the right? First, if a patient has a fever, the tissues will require more oxygen. Also, if CO2 levels rise in the blood, then oxygen will be forced to go to the tissues. How does the CO2 level rise in the blood? Answer, you don't blow it out. And that's called hypoventilation. And a rise in CO2 level causes a decrease in the blood pH. And this is called respiratory acidosis. So the goal is not to allow the graph to shift. And if it does, you can correct the CO2 and or the temperature to help bring the graph back to normal. Well, there you have it, the dissociation curve, a fun tool to help you, the practitioner.
Okay, these to answer your questions yesterday.
Welcome to my channel Renovate. In this video, I'm going to discuss with you guys the contraction and the action potential of the smooth muscle and how the action potential is generated in the smooth muscle with the concept of two waves, that is the slow wave and the spikes. We're going to discuss in this video. So starting from the action potential in the smooth muscle. One thing we should clear about the smooth muscles that these smooth muscles are act as a syncytium. The smooth muscles are attached with one another through our gap junctions. So if the action potential is generated in any one point of the smooth muscle, this will going to contract all the muscles of the GIT tract, all the layers of the GIT tract, and because this, there will be a generation of action potential and spreading of the muscle contraction in all the directions. So this concept was clear that the smooth muscle will act as a syncytium. Now coming to two important waves that are present in a smooth muscle. The slow waves are simply the changing in the resting membrane potential, the undulating resting membrane potential, that is about -50 to -60 millivolt. In between this is the resting membrane potential for the smooth muscle. So when there is a slow change or there is a increase or decrease that is not equal to a threshold but less than threshold, there is an increase and decrease and changes in the resting membrane potential will simply causing these slow waves. These slow waves are at the intensity of 5 to 15 millivolt and at a frequency of about 3 to 12 per minute along the different sides of the GIT tract. These slow wave, the causes of slow wave are because of the change in the resting membrane potential below the level of threshold, and also these slow waves may occur because of the presence of the contraction of the cells that are special cells called as the intestinal cells of the Kegel. So these are the two reasons for causing these slow waves, and they are just slowly present in the smooth muscle, mostly in the GIT tract. Now, these waves do not cause the action potential. Why? Because these waves does not reach the threshold level, that was plus 40. That was plus 40. This is a threshold level for causing the action potential. But these waves does not reach the threshold, so that they do not cause the action potential to be generated. So if the action potential is not generated, no muscle contraction can take place at all. Now coming to the second wave that here you can see is the spike waves. These spike waves are the true action potential waves, and these waves occur when the slow waves become positive or when the resting membrane potential become more positive than the 40 millivolt. When the -40 millivolt is achieved and more positive than the -millivolt is achieved, there will be a presence of a spike waves, and these spikes will produce 1 to 10 spikes per second. These spikes will cause ultimately the opening of the sodium channels that are present in the cells. These sodium channels will ultimately causing the rushing of the sodium, and it is causing the depolarization. Here you can see this is a depolarization because this was greater than the -40. The positivity occur and there is a depolarization. When there is a depolarization because of the entry of sodium channels, what happens? There will be an opening of calcium channels. When there is slow opening of calcium channel occur, these calcium channel will ultimately causing the muscle contractions. And these spikes here you can see they are 1 to 10 per second. So they are very much greater than.
Okay, I will share you the video later. I mean, in the email. I will send you the email. Okay. If you have any questions, you can email me or WhatsApp me. Okay. With that, I think. Thank you very much.
Thank you so much, Dr. Sina.
Okay. If you have any questions, you can email me. Yeah. Okay. Okay.
Thank you again. So with the conclusion of our second speaker, we have another break around 30 minutes. For you guys, got toilet break or anything. Thank you.